Okay, so we're going to begin now. So hi, everybody. Thank you for being here tonight. Before we begin, I'll just give a quick introduction. My name is Tamar Itzkowitz, and I'm going to be moderating tonight's event. I'm a first-year medical student at Hackensack Meridian School of Medicine, and I'm also on the board of the JOWMA Women's Health Committee. Thank you for being here, and thank you for registering for JOWMA's webinar. We're going to talk all about OB emergencies. Before we begin, if I can ask you to take the time to complete a really short pre-session survey, it just helps us improve our ability to modify future webinars to your needs. For those who fill out both the pre and post-session survey, the post-session survey will be made available to you over email right after the webinar. But for those who fill out both of the surveys, you're going to be entered into a raffle to win a $50 Amazon gift card. Just letting you know that the survey is completely anonymous. The survey link is going to be posted into the chat box. There is going to be a Q&A session at the end of the event. You can ask questions using the Q&A function on Zoom. Just please make sure to press the Remain Anonymous button when you submit your question. Also, just be mindful that we can't give any sort of individualized medical advice on this forum, and so all questions should be broad. All right, we're going to begin. First up, we have Mrs. Yardena Goldstein, who you may know as Yardena's Closet on Instagram. She is a fashion enthusiast, a mom of two, and a mental health advocate. She's going to share her personal story of postpartum hemorrhage, but before she begins, I just want to give a very quick trigger warning for anyone on here who doesn't feel like they are at a place where they're able to hear this story. I'm just going to let you know that for the next 10 minutes, she's going to be speaking. Okay, and that is all. Yardena, you have the floor.
Thank you so much for having me. It's really an honor to be a part of this panel with such incredible professionals in the field. If I mistaken any medication or any procedure that I had done, please correct me. So I do apologize in advance if I don't know the correct terminology. So just a little bit of background, me and my husband, before we got married or before we got engaged, we did genetic testing. And we did the testing through Stern NYU, and we found out that, thank God, nothing was crossed over, but that I did have a genetic disorder called factor 11 disorder, which is a blood clotting disorder. And so it can range within like mild to severe. So I didn't know what my levels were. All they told me was when I got pregnant to go ahead and get it checked out. So I got pregnant with my first daughter after we were married, and I went to my 6-week appointment and she said, okay, do you have your genetic testing done? I said, yes. They did tell me that I had factor 11 disorder. So she said, not a problem. Go to a hematologist towards your end of your pregnancy. The only thing that it might affect is your epidural. Obviously that was like, oh my God, it's affecting my epidural. I wanted an epidural very badly. So to me, that was like, oh no, what am I going to do? Fast forward, I had an incredible pregnancy. My last trimester came. 32 weeks, I went to a random hematologist that I just found that my doctor had referred me to, and he did my levels for for factor 11. And when I got the phone call about what my levels were, he seemed very unhappy, to say the least. So just to give you a overall picture, and please correct me if I'm wrong, all the doctors on here, but the normal levels of factor 11 is anywhere from 50 to 150. That would be your normal range. You don't have factor 11. The 30 to 50 range would be that you have mild factor 11, and anything below 30 would mean that you're in the severe category. So I found out that I was hanging around a 4 and a 6. So when I was doing my blood levels, so my factor 11 levels were between 4 and 6 every time I did blood tests from then on. And they were really concerned. We decided to have a game plan. My OB, my maternal fetal medicine doctor, and my hematologist were all on board that they were going to pump me up with fresh frozen plasma, or FFPs, which I'll probably refer to it as, before delivery. So they wanted to induce me so that they can be in control of the situation. And I went in 6 hours prior to my scheduled induction. I was hooked up to 4 different IVs on my body, and they pumped me up with FFPs. I was in labor for 36 hours, pushed for 2 hours. Great. Baby was beautiful, healthy. I did not hemorrhage after then. I had the epidural stuck in the tube stuck in my back for about 24 hours as they rolled me to the MFCU, which is the maternal fetal care unit, because they wanted to continue giving me FFPs for the next 2 days while I was staying there. So they did that. Everything went well. I ended up getting a pretty bad allergic reaction in the hospital to the FFPs just because I think it was overload on my body at that point. But I was able to go home. They kept me 1 extra night in the hospital and I went home 4 days postpartum. Everything was great. Bleeding was under control. They were not concerned whatsoever. I went to my doctor a week later. Bleeding was under control. They were very satisfied with how the delivery went. And I was on my way. I wasn't going to see her until my 6-week postpartum. So 2 weeks postpartum, I'm just sitting on my couch, hanging out with my new baby, and my husband is there. And I started to feel like a large gush come out. And so I was like, that's weird. So I went to the restroom, and again, trigger warning. This is where the trigger warning starts for anybody who needs one. I went to the restroom and there was about a baseball-sized blood clot sitting in my pad. And so obviously I freaked out and I called my OB right away, and I'm sitting on the toilet and blood is just pouring out into the toilet. And I called her and she goes, okay, I'm sending over medication that's called Amicar to CVS that's down the block. You're going to go pick it up and hopefully it'll help with the bleeding. So of course, CVS, it took like an hour. So I didn't get the medication on time. At that point, I had already bled through 4 or 5 hospital grade pads, and massive blood clots were coming out at this point, and I felt them passing. So I called my OB 45 minutes later and I said, I'm going to the ER. This is not normal. And she said, good, go to the ER. I'm calling them, telling them that you're coming. At this point, I'm very nauseous and I'm losing a lot of blood. I can feel the blood just pouring out of me. And I get to the ER, and it's, of course, this is pre-COVID. So it was packed before pre-COVID also. And I was just sitting in the ER. They started taking my blood pressure and triage, and I started throwing up. I was just losing a lot of blood. And this is kind of where the story on my end gets a little bit iffy. I have the fill in the blanks for my husband because at this point I'm in and out of consciousness. They take me right back to the ER. They start to put in a balloon in my uterus to try to put pressure on the walls to help the bleeding. After about 15, 20 minutes, it did not work. And they rushed me up to the IR, which is intraradial radiology. Sorry if I got that wrong. Like a surgery room, but I went under anesthesia. So I was completely knocked out, but they basically did a uterine embolization, which they stuck a clamp through my thigh to clamp the uterine artery to stop it from bleeding. And the next thing, I don't even remember going up to that. The last thing I remember is being wheeled into an ER room and the doctor saying, if you were in a third world country, you'd be dead in 2 hours. So I was like, that's great. And so I wake up, I don't know how much later, and I'm in the ICU. And the only reason why I know I was in the ICU was because my husband and my dad was there at the time, and they had told me, welcome to the ICU. And so I wasn't allowed to move my leg. I was there. From what they told me, I was in and out of, being awake from anesthesia at that point. I was very out of it. I lost a lot of blood. I think I got about 4 units of blood by that point. Along with FFPs, they were pumping me up with FFPs again. And I was moved down, thankfully, to the MFCU. They brought me back down to the maternal fetal care unit 24 hours after the ICU. They thought everything looked okay at that point. From that, I was in the hospital and they started giving me a medication that is called Metrogen, which essentially wants and allows your body to form clots and push them out. If I'm wrong in any sense, please correct me. The first time I got that medication, it literally felt like I was in labor again because of how many clots were in my uterus at the time. And it was very unpleasant. And so they essentially just wanted me to pass the clots on my own. And my body, for some reason, was not allowing it to do so. At that point, I was barely bleeding, and they think it was because of the IR procedure that I got, that they clamped the artery, and then it kind of just like cut off all blood supply. At this point, I was having talks with my OB and the residents that I might not be able to have kids anymore because they blocked off the blood supply to my uterine artery, and they weren't sure if it was going to unclamp on its own. And they obviously did not want to go back in there and unclamp it because it was a very risky procedure. So I ended up getting a very bad blood infection because of the IR procedure. And I was running a fever when I was staying in the hospital, and still no blood clots were coming out at that point. I was pretty much just dry pads. And so my OB comes in, she goes, this is about 6 days later when I'm in the hospital and they're just monitoring me. And she tells me that I'm going to have a DNC. And again, I was just under anesthesia 6 days prior. I was already very out of it from the amount of blood that I lost. I wasn't eating. They were pumping me up with FFPs. And I look at her and I just said, I'm done. Like, I can't do this anymore. I was sick. I was running a fever. There was very scary moments in the hospital when I was having that infection with just a bunch of doctors that I didn't know coming in and out, not saying anything to me, just running in and out, taking blood pressure, taking fever, checking my fever. So it was pretty scary. But at 7 days when I was in the hospital, they finally brought me back to a DNC, and my OB was able to clean out my uterus. And ever since then, I was in the hospital for another 24 hours, and they did an ultrasound to see if any of the blood clots were still there. And thank God, nothing was there. I was discharged from the hospital. I was like, peace out, I'm done. And so I left, and I went to my OB about a week later just to do another ultrasound to make sure that there were no more blood clots. And there was another blood clot forming in my uterus, which of course they were not happy about. But this blood clot, even though it was large, it ended up shedding on its own. So I was very blessed that that had happened. So that was my experience going through my postpartum hemorrhage. So fast forward 2 years later, now I had another baby where they did not let me go past 37 weeks because they were very nervous about me going into labor on my own. And they put me on Amicar before, about a month before I was scheduled. I had a C-section, especially because my doctor wanted to go in and really clean me out in case anything were to happen. And thank God, everything was successful. I was on Amicar before and after, and I was on high risk and monitoring the whole time. So thankfully it was just one time that scary incident happened, but I'm forever grateful that I got genetic testing, and that my team and my hematologist, my OB, my MFM, they were absolutely incredible. And they took care of me like I was their own daughter in a way. So yeah, that's my story.
That is a really crazy story. It's crazier than I remember you telling it to me the first time. And Dr. Hellman is going to speak about postpartum hemorrhage more and interventional radiology and delayed PPHs, which is our acronym for postpartum hemorrhage. I guess I would just want to ask you, Yardena, like, did you feel like maybe if you had kind of any concept of this ahead of time, or a little bit, like, had you ever thought that a postpartum hemorrhage could be what it was? Was it ever in your like frame of mind? So I know as OB residents, when we first step onto, like, every OB medical student, the first time they step into a C-section is like, whoa, that was a lot bloodier than I thought it was going to be.
Yeah. So actually, just to touch on the C-section, I didn't lose that much blood in my C-section. And my hematologist was in the room also, and he kept coming behind the curtain. He's like, damn, you're good. You're good. He's like, you're doing so well. I'm so surprised. So he's awesome. But I was not really aware of what specifically could happen during a hemorrhage. I was just told that the epidural site could be a site of where I could lose a lot of blood. And they didn't even use the word hemorrhage, to be honest. They just said a lot of blood could be lost from that site. And we want your body to be able to clot on its own because your levels are so low. It's probably not going to happen, which it did on its own. I did not bleed at the wound site, which was to their surprise. I think if I would have known beforehand, I probably would have been a lot more on top of my health postpartum, because I did not let myself breathe, so to say. I know they say, like, you know, sleep when the baby sleeps, but I did not. I'm the type of person that cannot sit home so long. So I definitely would have been more relaxed. And if I knew that this was such a prominent thing that could happen, and that they really sat me down and warned me that this is very, like, this could happen and this is very real, and we want to try to avoid that at all costs, I think I definitely probably would have taken care of myself pre and after that happened.
Thank you so much for sharing. I'm just gonna tell everybody real quick. So factor 11 is something very specific to your story, and it's not going to be the common reason why most people have postpartum hemorrhages. And Dr. Hellman will talk about it more. But postpartum hemorrhages are very common, and so it is super important to kind of hear what's up, and just to know what could be. And also I told Dr. Hellman, but in LA, there's a shortage of Cedars-Sinai of blood. And this is one of the reasons why blood is just so important to the OB unit. So with that, I'm going to turn it over. Thank you so much, Yardena. All right, Tamar.
Yes, thank you so much for sharing that story. And yeah, we'll be moving on to our next speaker. Up next, we have Dr. Tirtza Strauss. Dr. Tirtza Strauss was an Ann Schreiber Scholar at the S. Daniel Abraham Honors Program at Yeshiva University, where she graduated summa cum laude. Dr. Strauss completed medical school at Albert Einstein College of Medicine, where she was also an Ann Schreiber Scholar. Dr. Strauss completed her obstetrics and gynecology residency at Northwell Health, or also known as North Shore LIJ, where she was the academic chief resident and received the Society for Maternal Fetal Medicine Award for Excellence in Obstetrics. Dr. Strauss is currently pursuing a fellowship in maternal fetal medicine at Mount Sinai West in Manhattan, and she is board certified in obstetrics and gynecology.
Sorry, bear with me 1 second while I share my screen. Hi, everyone. Let's get started. So tonight we're going to be talking about obstetric emergencies. So first to start, I have no financial disclosures, and this presentation does not constitute personal medical advice and should not replace an appointment with your physician. So let's talk about our learning objectives for tonight. Tonight we're going to talk about preeclampsia, and we're going to talk about shoulder dystocia. This talk is not meant to be scary. Rather, it is meant to educate and empower you to take best care of yourself during your pregnancy and during postpartum. So what is preeclampsia? Preeclampsia is a blood pressure disorder that can happen during pregnancy or soon after birth. It affects 5 to 8% of births in the US and is a leading cause of death worldwide of women, fetuses, and infants. It can develop without you realizing it, so it's important to recognize the warning signs. Let's dial it back a bit and start with normal blood pressure. A normal blood pressure is less than 120/80. The top number is called your systolic blood pressure, and the bottom number is called your diastolic blood pressure. Your blood pressure should be checked at every single prenatal visit. There is a spectrum of disease in the hypertension of pregnancy preeclampsia spectrum, and we'll get to a few of them. So first, let's start with gestational hypertension. So what is gestational hypertension? This is when you have an elevated blood pressure after 20 weeks of pregnancy. It's when your systolic blood pressure is over 140 or your diastolic pressure is over 90 after 20 weeks, and you have no history of high blood pressure outside of pregnancy. If you develop these high blood pressures, your doctor will monitor your blood laboratory values that we'll get to, your urine, and will also monitor your baby with ultrasounds until it's time for delivery. In women who develop gestational hypertension, there is a risk of developing preeclampsia afterwards, which usually occurs about 1 to 3 weeks after the hypertension starts. So what is preeclampsia? Preeclampsia is when you have hypertension of pregnancy along with protein in your urine. Many women also have what we call preeclampsia with severe features, which is when you have either severe range blood pressures, which is when your systolic or your top number is 160 or above, or your diastolic blood pressure is 110 and above, or have just plain hypertension with laboratory abnormalities in the blood that reflect signs of damage to the liver, kidney, or the platelets, or symptoms like headaches, spots in your eyes, or pain where the liver is. So when does preeclampsia occur? Preeclampsia occurs after 20 weeks of pregnancy. About 95% of preeclampsia occurs during pregnancy, but about 5% occurs after giving birth, usually within the first 1 to 2 weeks. Now that we've discussed preeclampsia, let's talk about some of the risk factors for preeclampsia. Having a history of preeclampsia in a previous pregnancy, having twins or triplets or multiple pregnancy, having hypertension that exists before pregnancy, having diabetes, having kidney disease, or having autoimmune disease like lupus or Crohn's are some of the major risk factors for developing preeclampsia during your pregnancy. If you have any of these risk factors, it's important to discuss with your doctor about starting baby aspirin at around 12 weeks in your pregnancy to decrease your risk of preeclampsia. So now that we've discussed kind of what preeclampsia is and why and what are the risk factors, why is it an emergency? In women who have preeclampsia without severe features, so that's the hypertension and the urine and the protein in the urine, there's about a 1 in 400 chance of having a seizure, a special seizure called eclampsia. In women who have preeclampsia with severe features, this risk has increased to about 1 in 50. In women who have severe preeclampsia with severe range blood pressure, there is also a 5 times increased risk of stroke. Additionally, preeclampsia is associated with adverse maternal and fetal outcomes. So this is eclampsia, the special seizure that women with preeclampsia are at risk for. Now that we've talked about preeclampsia, let's talk about how to treat it. In women who have preeclampsia without severe features, delivery is recommended at 37 weeks. Before delivery, your doctor will monitor you very closely. You will have weekly blood tests and urine tests, and your doctor will monitor your baby with ultrasound. In women who have preeclampsia with severe features, delivery is recommended by 34 weeks unless indicated sooner with laboratory abnormalities or headaches that don't go away or blood pressure that's difficult to control. A medicine called magnesium is started to prevent these eclamptic seizures from occurring, and it is very important to control blood pressure in a timely fashion. So why is severe blood pressure so scary? The risk of stroke correlates with the degree of blood pressure elevation. And therefore, it is important to decrease blood pressure very quickly. From the time of severe blood pressure, the antihypertensive medicines are supposed to be given within the first 30 to 60 minutes of the blood pressure and can be repeated 10 minutes in order to bring down the blood pressure quickly to decrease the risk of stroke. Now that we've discussed preeclampsia, its treatment, let's talk about some warning signs at home to look out for so that you can best empower yourself to take care of your health. So having a blood pressure with a systolic blood pressure of 140 or a diastolic of 90, along with headaches, spots in your eyes, or pain in the right upper quadrant, or just having a severe range blood pressure with either a systolic blood pressure of 160 or a diastolic blood pressure of 110, these are all reasons to be evaluated urgently at a labor and delivery triage. Now that we've talked about pregnancy, let's move to postpartum. So pregnancy is the body's natural stress test. And we have good evidence that women who have preeclampsia in a pregnancy are at increased risk of hypertension and heart disease. In the first 15 years after a pregnancy complicated by preeclampsia, women have double the risk of cardiovascular disease, clots, and strokes. And there's about a 40% chance of developing long-standing hypertension after the first 2 to 7 years after delivery. Therefore, it's very important to follow closely with your primary care doctor to best take care of your heart. Additionally, if you're considering having another baby, it's important to discuss starting aspirin early for your next pregnancy to prevent preeclampsia from occurring. Now that we've discussed preeclampsia, let's move to shoulder dystocia. So what is a shoulder dystocia? A shoulder dystocia is when the baby's shoulder gets stuck at delivery, and extra maneuvers are required to deliver your baby. This occurs at 0.2 to 3% of all vaginal deliveries. Here is a graphic to help explain. The largest part of the baby at the time of delivery is the diameter of the shoulder. And therefore, once the baby's head delivers, sometimes the shoulders can get stuck behind the pubic bone. What are some of the risk factors for shoulder dystocia? Having a large baby, obesity, diabetes, having a shoulder dystocia in a previous pregnancy, having a vacuum or a forceps delivery, having a very short, or as we use the word, precipitous labor, or having a very long second stage of labor, which is the pushing stage. However, even with all these risk factors, a shoulder dystocia can be hard to predict and prevent, and therefore it's important to manage quickly. So why is a shoulder dystocia an emergency? After your baby's head is born, your baby's shoulder needs to be released quickly so the baby's body can be born and start breathing air into the baby's lungs. The goal of quick management is to prevent the baby from choking and to prevent permanent nerve damage from happening to the baby. So you may have a shoulder dystocia during your pregnancy, and you may notice everybody running in the room, a code being called, and you may wonder what is going on. So we have a whole team that's prepared to respond to a shoulder dystocia code to best take care of you and your baby. So there will be nursing, anesthesia, OB, and pediatric staff to help support. Your doctor will instruct you to stop pushing and come to the edge of your bed. And there will be different maneuvers tried to help the baby's shoulder deliver. So one of the team member may apply suprapubic pressure to help release the baby's shoulder, or they may push your legs back in order to change the shape of your pelvis to help the baby's shoulder deliver. It's important to listen to your doctor and to follow directions. It's very scary, but it's important to follow follow the instructions to help and to stay calm. So I know this sounds very scary, but the good news is that most cases of shoulder dystocia do not result in permanent nerve damage to the baby, and your doctors practice drills for this emergency. So this is me coaching my residents through a safe and quick management of shoulder dystocia. They all did very well. And then let's talk about the next pregnancy. So there's about a 10% risk of recurrence of shoulder dystocia. So depending on your values and your preferences, you may want to discuss the mode of delivery with your doctor. If the baby's shoulder comes out easily and there's no residual nerve damage and you want to have another vaginal delivery, this is something to bring up to your doctor. However, if your baby has permanent nerve damage, or maybe this was a very traumatic and scary experience for you and your family, you may want to discuss the option of a C-section with your doctor. Additionally, if the shoulder dystocia occurred because your baby was large, which we call over 4,000 grams, you want to be screened early for diabetes in pregnancy, because this is a risk factor for gestational diabetes. So thank you all for listening, and I look forward to your questions.
Oops, my mute was on. Thank you so much for sharing that. We're going to move on to our next speaker, and then at the end, we're going to direct questions to both Dr. Strauss and Dr. Hellman. So I'll just introduce Dr. Hellman. As an experienced board-certified OBGYN, Dr. Elissa Hellman has been in clinical practice for over 11 years. She's also the physician at the Confident Kala, which is a telemedicine gynecology practice focused on the needs of Jewish women who observe Tahara Samishpacha. Throughout her years as a clinician, she noticed a gap in women's health awareness and education. This developed into a special interest in patient education and being a resource for the Jewish community in relation to body awareness and women's preventative health, starting from a young age.
All right, thank you. Okay, hopefully this works. Okay, there we go. All right, so I am here today, hi everyone, to talk about the next two topics in our OB emergency talk, postpartum hemorrhage and non-reassuring fetal heart tracing. All right, so my deep thought for the night is that the difference between a low-risk patient and a high-risk patient is 1 second. So you can be the most like healthy, low-risk pregnant woman, and then all of a sudden something happens in the delivery room and you are now very high risk with a scary situation going on. And, you know, it can be really scary, right? You're not expecting it. All of a sudden there's a million people in the room, like Dr. Strauss was saying, and you're worried about you, you're worried about the baby, and you have like no clue what's going on. But just remember that you, like your doctor, your team went through training to deal with this. So even though you are scared and worried, your team is prepared and knows what to do to help you and your baby, just like Dr. Strauss was showing you those pictures of her kind of running through practice drills so that when it comes to real life, we've been through it and we know what to do. And it's just kind of good for you to have insight into like what we're doing and the reasons behind like what we're thinking, even though you are also in a scary moment. All right, so postpartum hemorrhage. Let me try to get this away. Can you guys see this? Maybe not. Okay. Hold on 1 sec, sorry. Okay, so postpartum hemorrhage, this top picture here, this is me, right? And this is why we wear scrubs, because there is a lot of blood during delivery. And it's a very, very bloody event, but how much is too much, right? So after vaginal delivery, about more than 400 milliliters is too much. That's considered a postpartum hemorrhage. And after a C-section, we can tolerate a little bit more because we expect some more blood loss during surgery. So it's over 1,000 millimeters. And in pregnancy itself, we lose blood much faster than when we're not pregnant. Your blood vessels have grown. They can be like 3 times the size that they normally are, sometimes even more. They're bigger, they're wider. The uterus itself is holding about 1/5 of your blood volume because so much blood is going through it to kind of feed your baby, and the organ itself is growing along with your baby. That a lot more blood than usual when you're not pregnant is going through it. All right, so we know that we expect that significant blood loss on the day of delivery, and your body starts to prepare for it. And it starts to prepare for it very early on in pregnancy. So what is it doing? So one thing that it does is the blood volume almost doubles. This is actually a reason why we see like the normal anemia of pregnancy, because the blood volume, like the liquid part of it, kind of doubles, but not all of the red blood cells double. So that's why we see a little bit of what's called a dilutional anemia. We're also more prone to blood clotting when we're pregnant, which kind of sounds like it's supposed to be a bad thing, but it's actually really a good thing. So we don't want blood clots in places we don't want them, like our lungs or our leg, but we do want to clot when we know that we are preparing for a very bloody day. And then also postpartum contractions. So that's somewhat uncomfortable, but once the baby is out, right? So the organ that is growing your baby pushes it out, then also right after the baby's born contracts down, and it knows to do that. That's just a normal response after delivery to help clamp down on those blood vessels that are in the uterus and stop the bleeding. But, and there's always a but, sometimes all of those mechanisms that are already in place is not enough. So why would a hemorrhage occur? So one reason would be the actual uterine tone or no tone or lack thereof, right? So when would this happen? One, you could have an overdistended uterus, right? Where the things get super stretched out and it's kind of hard to get back to its smaller contracted down state. That would happen when you have a very large baby, right? Because your uterus is really used to being stretched out a little more than usual, like 9, 10, 11 pounds. If you have multiple babies, so twins or triplets in there, right? There's just more baby in there that has stretched the uterus out. Multiple pregnancies. So if you get up to 4, 5, 6, 7, 8, 9 pregnancies, your uterus is kind of used to being in this over-distended state. And it doesn't always kind of remember, kind of personalizing the uterus, but it doesn't really always remember to kind of go back down to its small, contracted, unpregnant size. Also, you can have kind of a lazy or tired uterus, and that happens when you've been in labor for a very long time, and your uterus is just contracting, and working, or you've been on Pitocin for a very long time, and it's just, once baby's out, it's like, okay, my work is done, I'm going to stop contracting, and so sometimes we have a harder time making it clamp down. And then also infection is something, if you develop an infection during pregnancy or during kind of the labor process or postpartum, the tissue itself becomes very inflamed. It's a little bit softer, and it doesn't work as well as in its non-infected state. So that also, there's a little harder of a time contracting down. All right, number 2, lacerations. This is another reason why we may see some bleeding. And laceration is just a fancy word for tearing. And so we can get tearing really anywhere in the whole system. So the vagina can tear as the baby comes out. The cervix itself can tear. That's why it's very important to not start pushing the baby out until you're at 10 centimeters dilated, when the cervix is kind of moved away. You can also get a tear in your uterus, which is called a uterine rupture, which we will talk about a little bit later. And then it's also in the tissues kind of surrounding the uterus inside the pelvis. And so remember, like we talked about the blood vessels in pregnancy getting much bigger. We're also talking about all the regions in the pelvic floor. And, you can see that on yourself. Sometimes you get varicose veins. Sometimes you get them on the vulva and the vagina itself. So you can actually see that those blood vessels are getting much bigger with all that pressure. So if those were to tear, and don't be scared, usually the external ones don't really tear during delivery, but the blood vessels inside, which are just as big, if they do tear, you lose a lot more blood than if you just got like a little cut on your arm. All right, number 3. So this is kind of like a really big topic that I'm going to kind of brush over. There's a lot of placental reasons for postpartum hemorrhage. So the placenta itself is basically a kind of plate-sized organ that is maternal blood vessels and fetal blood vessels intertwined. They don't share blood, but they're intertwined, and oxygen and nutrients kind of shift back and forth from mom to baby, and that's how baby gets all of its oxygen and its nutrients. And after delivery, there's a very nice tissue plane right here. This is kind of the normal tissue plane that it just kind of shears off, and the placenta spontaneously delivers. Now, we can also have problems with the placenta, and because it's just a bunch of blood vessels, if there's a problem with it, we can see hemorrhage come after that. So this first picture here, this is normal, and then if there isn't that nice tissue plane, it can kind of grow into the uterus, into different layers of it, and even through it. This is called an accreta, increta, percreta, based on how far into the uterus it has grown. And now once baby's out and delivered, and now it's time for the placenta to come out, it doesn't come off nicely. And you're basically just kind of bleeding through it, or we try to take it off because you can't keep your placenta forever. And that bed, that area that it was on the uterus, is basically just one big tear that bleeds a lot. So that sometimes we can see a hemorrhage there. Also in this next picture off to the side, something called the placenta previa. This is where the placenta is the first thing coming out, like next to the cervix, right? Like before the baby's coming out. Generally, we want baby out before placenta, right? Because the baby needs the placenta to stay attached there. So we can't get a baby out through the cervix if the placenta is blocking the way. And so what happens, especially in labor, is when the cervix starts to dilate and open, we now have an exposed part of the placenta, which again, just blood vessels, and we're going to start to see bleeding. And sometimes we can see that earlier on than term in pregnancy. Sometimes we'll see that bleeding preterm, and ultrasound does help diagnose this. Something called an abruption. This is this lower picture here. There's two types of an abruption. Generally, we want the placenta to come off after the baby is out, right? Because you don't need it anymore. But there are certain instances where the placenta starts to detach before the baby is out. Now, this is life-threatening for the baby, right? Because the baby has to be connected to mom in some way. And if it starts to detach, that is an emergency, and we have to deliver, no matter how far along mom is. And then we usually can see this, an abruption, because you start having bleeding, right? That placenta is coming off, then the blood just kind of flows out of the uterus and the cervix in this first picture here. And that is usually the sign that would kind of start cluing us into that happening, along with identifying any other risk factors in pregnancy. Preeclampsia actually being one of them that Dr. Strauss just talked about. More scary actually is a placental abruption that is hidden. And the reason it can be hidden, once it shears off, that blood somehow, just due to the anatomy, it just kind of forms as a enlarging blood clot, and it actually, the blood is not coming out of the vagina. This usually would present as pretty severe pain and contractions, but it may be too progressed before we can actually, before we identify it or before mom starts to become symptomatic. So this again would be another huge emergency. And then one thing I don't have a picture here for is a retained piece of the placenta, where we think the placenta came out, baby came out, placenta came out, everything went well. And then, maybe a few hours later, or even a few days or a few weeks later, there is kind of a bigger hemorrhage than we would expect. You can do an ultrasound and we can actually tell that there's a possibility that there is still a retained piece of the placenta in there. So one of the things we do to kind of help avoid that after a delivery, we usually check the placenta and make sure that there's no pieces missing. So these are placental reasons for hemorrhage. Now, oh, sorry, one more thing. I did not mention here also two other ones. One would be bleeding disorders, right? So bleeding disorders, just like Yardena had, right? So it's great when we can identify it beforehand. So that would be another reason, even if delivery of baby and placenta went well, just because there is increased bleeding, and if your blood doesn't clot as efficiently, that can cause hemorrhage. And then something called a uterine inversion, which just means that the uterus kind of pops inside out. We can usually fix that super quick if we identify it, but that can also cause bleeding. All right, so when we talk about emergencies, right, what's the best way to deal with them? To prevent them. So there is very kind of established guidelines after someone delivers their baby to actively do things to help prevent postpartum hemorrhage. And the three main parts of this protocol is to give Pitocin. Pitocin is the synthetic form of oxytocin, which is the chemical that helps cause your body to have contractions, right? This is one of the things that we can give to induce labor and induce contractions. But even if you were never on Pitocin during your labor, we do give a small dose of Pitocin right after delivery to strongly encourage your uterus to very quickly contract down to avoid that kind of lazy tone. One other thing we do is uterine massage. We kind of rub your belly. We always say, hey, let's doing a little massage now. It's not one of those nice spa music, gentle massages. Usually it's just kind of like mashing on your abdomen for a little bit. And then something called umbilical cord traction, where we very, very gently just kind of hold the umbilical cord and kind of encourage it to come. We never want to pull hard because we don't want to rip anything before it's ready to come out, but that gentle kind of traction does encourage the nice shearing of that layer, separating the placenta from where it was embedded in the uterus. All right, so what if none of that works though, right? Because there's definitely instances where it doesn't. So then we kind of move into treatment phase, of which there are, a lot of kind of different categories we can talk about. So one is that manual, so uterine massage. Even though we kind of did that preventatively, we can do it much more vigorously. We put a hand inside the vagina. We're kind of touching the cervix and that lower part of the uterus, which would be right here. And then we have our other hand over the belly and kind of pushing on the what's called the fundus, the top of the uterus, and just kind of like kneading it together. Almost like you're kneading dough, kind of, to really help contract it down. And that very often does work. Then we're moving on to medical treatments. And, there's a lot of them. And Yardena did touch on one, the methergin. So there's Pitocin, there's methergin, Hemabate, and Cytotec. These 4 medications help with contraction, and they all help in different ways. Some of them we can use or can't use based on other medical issues in the patient, but generally these work very nicely. Then we move on to things that help blood clot better. So tranexamic acid is one of them. We give that through the IV. And then we also, like Sahar, like Dr. Wertheimer was saying, we can give blood transfusions, right? Like if we think that you're bleeding too much and these medications are taking a little longer to work, or we have to move on to something else, we also need to keep in mind, hey, you're still losing blood, even though we're trying to help you, we need to start replacing what you've lost. And one of the things that Yardena was talking about, not only did she probably get blood, like red blood cells, like to kind of boost up her blood volume, but she also got something called FFP. FFP has blood clotting factors in it, because that was the problem. That was like she had a clotting factor deficiency. So she needed that kind of extra blood product that is usually not standardly given unless someone loses an immense amount of blood. But that's just like one more thing in our arsenal of blood products. And then antibiotics, right? Antibiotics are not going to help anything quickly in the moment, but if we suspect there's infection, and that's one of the reasons for lack of uterine contraction and tone, we also need to do that. And also with a lot of manual, putting our hands in the vagina and inside the uterus and really kind of working on it, you're just at a little higher risk for infection, because we've been in there so much trying to work on you, that we generally will give antibiotics because you're at risk of infection kind of later on in the day. All right, and then mechanical. So these actually are really, really cool. And I think that Yardena had mentioned she had the balloon one, which we'll talk about. So these are a mechanical way of stopping bleeding. So these are 2 devices that are on all labor and delivery floors. One is called the Bakri balloon. This is like, we put a little balloon inside the uterus that's kind of, not contracting down and it's bleeding. And it's a really big balloon, kind of like, I don't know, baseball, probably big baseball size or something. It's kind of pushes pressure onto the sides of the uterus to kind of clamp it off, right? To kind of block those blood vessels from losing their blood. We leave it in for a good 24 hours. And then after that, when hopefully the process of the bleeding has kind of slowed down or stopped, we slowly decrease the size of that balloon and then pull it out if there's no further bleeding. Then there's a newer product on the market that's wonderful. It's called Jada. And it's similar in that we put it inside the uterus, but instead of putting pressure outward onto the uterine walls, it actually creates a suction that pulls the uterine walls inward to help cause contraction and stop and kind of seal those blood vessels up. And they all work pretty quickly, like to put in. And then our last thing is surgical. There's lots of, right? If you have a laceration, you're going to put stitches in. There's actually special stitches we can do during a C-section. This bottom picture here is one of them. It's called a B-Lynch suture. It's kind of like suspenders around the uterus. We can do what Yardena had. It's called an uterine artery embolization. So this is basically where they put a little catheter through your femoral artery, which is like in the groin area, and they kind of snake it up around the uterine artery. This picture here is for fibroids. It's not postpartum, but I thought this was a good visual. And there's 2 main uterine arteries that go on either side of the uterus. There are a lot of other little accessory arteries going to the uterus as well. So even though we're trying to block off the big one to help stop the hemorrhage, the uterus still has blood supply. So basically what they do is they put a little catheter, snake it through, find the bleeding blood vessel, and they inject a material that kind of like a little foam almost that kind of causes a blood clot in there, not a blood clot, but a clot of this material to help stop the bleeding from coming out of it. And just like Yardena had, like you can have babies afterwards most of the time because of all those great accessory vessels that are much smaller that still supply the uterus with blood. Then really worst case scenario would be a hysterectomy where nothing is working and the bleeding is still happening, and to save your life we have to remove your uterus because that is the problem. Also what Yardena had, she had it all. She's a great poster child for all this, is the D&C, right, where we go inside the uterus, you're under anesthesia, and we just use either a suction or some gentle instruments to kind of remove all the blood clots and potential tissue that would be left in there. So those you would be under anesthesia for all of these. All right, so I know super fast, big overview. But let's move on to non-reassuring fetal heart tracings. So it's actually a really good topic to follow, because if something's happening with a hemorrhage and you're still pregnant, right, the baby's still in there and you're bleeding, we actually would probably see signs of that on a fetal heart rate tracing. And it can kind of clue us in to what is going on with mom in the uterus. So what are non-reassuring fetal heart tracings? It's basically a sign of fetal distress. Now, one caveat with this is that, one of the ACOG committee opinions, ACOG is kind of like a rule-making body for OBGYN, basically does admit and kind of say that we can monitor you in labor continuously, but it has not really been shown to significantly affect outcomes such as perinatal death and cerebral palsy when used for women with low risk pregnancies. Now, that low risk part is very important, because a lot of people are not low risk, right? If you are over age 35, if you have preeclampsia, gestational diabetes, low fluid, growth restriction, or any other placental issue or medical concern in pregnancy, both with you or the baby, you are not low risk. So this statement doesn't really apply to you. But if you are low risk, the benefit of continuous fetal monitoring is not really been shown. We still want you to be monitored, and then we would offer you what's called intermittent fetal monitoring, which is like be on the monitor for 20 minutes and then go off for an hour and just kind of go back and forth just to kind of check in with baby. However, we do see that continuous fetal monitoring was associated with having the rate of early neonatal seizures. And that means like babies having seizures in the nursery or the NICU, which can down the road impair brain function. All right, so what, before we kind of talk about like abnormal tracings, right? Like, why do we even monitor? What do fetal heart tracings tell us? So these top three things, baby's physiologic status, baby's oxygenation status, and baby's stress during labor, are really kind of all the same things, and we'll kind of talk about that. But one thing to kind of talk about with these, and we're going to go kind of have a very quick overview of how to read them, is that I can show you these slides and I can show you these pictures, but it is literally a snapshot of what is going on with this mom and this baby. And it is the reason I say it's incredibly nuanced is because it takes, I think, years to really feel comfortable assessing and monitoring when we're kind of in the gray area of interpreting what these tracings mean. We also need to take a step back and not just look at a 5-minute tracing, but like, how has this baby been doing over the last few hours? There are situations where 5 minutes matters, but to really assess the clinical picture and the long-term heart rate tracing is very important. And there's also like differences between your providers and your OBs and your midwives and who is willing to tolerate something that maybe someone else wouldn't, like whose little practices a little bit more nervously or a little bit more cautiously, or a little bit more like, hey, cowboyish, right? So there's, you may want to kind of talk with your doctors too about kind of where they hold with interpreting fetal heart rate tracings and where their threshold is for doing more of an emergent delivery. All right, so what causes fetal distress? interruption in blood flow, which has to do something with the uterus or the umbilical cord. There's less oxygen then delivered to the fetus, right? Because mom is the one who's giving the oxygen to the baby. The baby's metabolism then changes, produces more what's called lactate, which is just a byproduct of that metabolism, but that causes the fetal blood to be more acidic. So the pH goes down. So when a baby's blood starts to become more acidic, or what we call acidotic, this can lead to seizures and cerebral palsy. All right, but first, let's go over normal, just so we understand what normal is, just to have a framework of it. This is a textbook happy baby. And by happy, I mean like physiologically happy, right? This top one in the blue, this is the baby's heart rate tracing, and this bottom one here is what the uterus is doing. You see an increase in uterine tone every 3 minutes. This mom is having contractions every 3 minutes. And what are we looking at? We're looking at 3 things: the baseline rate, which is like what number this falls in, like the heart rate, beat to beat variability, which means how squiggly this little line is, and then heart rate accelerations, right? We want to see these little ups, right? The little mountains or hills that we see here. Those are all great. And we always want to compare what does the baby look like to what is going on with the mom's uterus. So let's look at baseline first. This is top layer, nice normal baseline. Normal is between 110 and 160 for a fetus. This one down here is tachycardia, right? This baby's heart rate tracing, I think looks like it's in like the 200s. That generally is a sign of infection. We will talk about bradycardia later on because that's a little bit more of an emergent situation. But this is a change that we can see just with baseline. Variability, very important. So again, remember this slide from before. This is normal. This is called moderate variability, the squiggliness of the line. And we see that moderate is where the beat to beat kind of changes about 5 to 25 beats per beat, or per second, I don't know, beats per minute, right? Then when we go up here, this is like more of a flat line, right? It's a very minimal variability. It's not really from beat to beat, it's not really changing very much. So it looks kind of flatter. Now, this can be extremely serious. This can be something that is a sign of the acidemia that we were talking about before. Or if we looked at the whole tracing, what does it look like before? What does it look like after this? Baby could be in a sleep cycle. Sleep cycles happen for about 20 to 40 minutes every so often. This baby could be premature. This baby could be exposed to some medications that do this, that are an effect of the medication that mom was on for some reason, like narcotics or, pain medication. Or the magnesium that Dr. Strauss was talking about before for preeclampsia. And really, it's going to be fine 20 minutes from now, and we don't need to act on it because we know why it's happening. It's when we don't have any of those other risk factors and we see this that is very concerning. Down here, called marked variability, that's when it's like super duper squiggly all over the place. That basically means that there's an increase in the sympathetic nervous system response of this baby, usually just like, right, when we get all kind of stressed out, our hearts start to race. So we usually see this when mom is pushing, just because there's like a lot going on and baby is kind of being squeezed out. All right, so remember, this is kind of where we're going to start talking about the emergency part of this. Decelerations, right? So this is when the heart rate's going down. Remember, here's the contractions down here. Accelerations are going up. We like seeing them going up, but now we're starting to learn about, well, what happens when the heart rate goes down? What does that mean? And we always want to compare it with contractions. So early decelerations, these are not a problem. These kind of are exactly mirror the uterine contractions, right, time-wise. And that basically means that head is getting compressed. So when we start to see those, we're like, oh, maybe like you're ready to push, or maybe that baby has come down. So that's something we would check on. Variable decelerations are usually in like a U or a V shape, and they can happen at any time, meaning variable, and they're usually a sign of cord compression. That's when maybe the uterus is contracting, and the blood supply to the cord is kind of decreased, and then all of a sudden the contraction releases and there's more blood flow. And those generally are not super concerning if they happen isolated. We get more concerned when they are repetitive. And then late decelerations, these are more concerning because they mean they're a sign of hypoxia or low oxygenation. Remember, we talked about what can happen when baby has less oxygen exposure. And The timing of this, we can tell if it's a late is we look at the peak of the contraction, and that's when the deceleration starts. So here you can see 3 in a row that happen right after each contraction has started. All right, so where's the emergency? And how do we know, like, what's urgent, what's emergent? Like that, we need to know, we need to be able to kind of look at a tracing quickly and kind of assess, do I need to act now? Do I need to act in 10 minutes? Do I need to prepare my team? What is going on? All right, so how is this baby doing? Like, what do we see here? How do we analyze this? So we have marked variability, right? Why would this be marked? Remember I talked about pushing. I look down here, I see the contractions. This mom is pushing. At least these last 2 contractions, I can tell that she's pushing. So that's probably what's going on of why I see this marked variability. I do, however, see repetitive variable late decelerations and a decreasing baseline, right? This baby is getting stressed out. It is having a hard time during pushing. Every single contraction, I start to see these decelerations, and the baby is having a hard time kind of getting up back there. Baby could be delivered in 1 push. Or this could be the beginning of pushing and I start seeing this and she has another 3 hours left to get this baby out. I don't know. That's why the clinical picture is so important, because that completely would change the management of a tracing like this. But this is something to be concerned about and have a plan for the immediate future. What about this baby? I think we hopefully can kind of all see that this is not going great. Minimal variability, repetitive late decelerations. This baby very likely is hypoxic and acidemic already. But is this something where baby needs to come out now in 10 minutes? You know, that's the decision that has to be made. This baby, I mean, they have kind of been waiting on this. Likely they are preparing for delivery. And then we see something called like a really big decel. Remember we were talking about that baseline, the tachycardia. Now we're on to bradycardia. So all of a sudden we get this really big heart rate deceleration. You know, there's really a great potential though that it can recover, right? Baby can kind of come back up and, you know, maybe what happened right here that caused that big bradycardia to happen. And did it come up nicely and did baby kind of recover afterwards? Reasons that this can happen are, many of them are fixable, right? Without an emergent delivery. So that's what we want to think about first. Is this uterus like super like contracting way too much and we need to relax it? Is there a prolonged cord compression? And we have to find a way to uncompress that cord. Did the mother's heart rate drop, right? That can happen often after an epidural. So it's very, very common that the heart rate drops after mom gets an epidural, and we see this effect in the baby, and then the baby recovers, okay? We also can see this if like the baby, you know, very quickly descends downward into the vagina and, you know, goes from, you know, 3 centimeters to 10 centimeters very, very quickly, or kind of drops and is ready to be delivered. We will sometimes see that. And then also a maternal seizure, we may see this as well. And that's something that Dr. Strauss also is talking about with eclampsia. Now, this is a little bit more of an emergency, right? It's called a terminal bradycardia, where this heart rate is dropping, 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 dropping. It's now in the 50s. 50s is low even for an adult, right? So this definitely is an emergent situation here. There is no return to baseline. This baby is not recovering. We can see that mom is contracting a lot. Could that be part of it? You know, is she on Pitocin? Is she not? We have no idea really what's going on here. All I know is I can see this baby needs to come out like now. All right, so when can all these kind of more emergent tracings happen where the baby's heart rate does not recover? We can see this with hemorrhage, right? Because all that blood is getting lost, baby's not getting oxygenation, and it just cannot like handle that stress. We see this with infection or sepsis. Sometimes we don't even know why it's happening, right? And we have to act quickly and deliver, and then kind of look back at everything based on what happened at the delivery to maybe clue us in. And sometimes we don't always know. Sometimes we do know though. So other reasons would be something called a prolapsed cord. This is where the cord actually falls out at some point during labor. The cervix is opening up where the cord can come out. I specifically showed a picture here with a breech of what's called a footling breech baby, where there's no butt or head to really plug up the cervix to kind of block it from the cord to come out. And if you just have feet that are moving around that are little, that cord can come out. What happens when the cord comes out? Your vagina is kind of more narrow. It will, it can compress that cord and literally cut off blood supply. So this is an emergency. You can also have a knot in the cord, right? We've all seen this. There's something called a loose knot, which is not a big deal because blood can still flow flow freely because it's loose, but we also can have a really tight knot where it's tied really, really tight, and that can cut off blood supply. So that is a very scary situation, and that is caused by babies just turning around and around during gestation, and they make their own knots. And then we also have something called uterine rupture. Uterine rupture is basically a laceration of the uterus before baby is out. So this is the main risk factor for this is having a previous C-section where there is a weakened area on the uterus. Very rarely would it happen spontaneously, but it could. And so the uterus basically ruptures open. There can be hemorrhage, and baby is not really in its normal environment anymore. Baby could actually even be out of the uterus itself. This is a very, very dangerous situation that requires emergent delivery. And this is actually a picture of a tracing of someone that had I'm almost done, that had a uterine rupture. Right here, you can see the baby is not doing so great during the contractions, and all of a sudden, heart rate just drops out. You can see it says here a vaginal exam was done, and there is no presenting part, meaning that we don't feel the baby anymore because the baby's up now in the uterus. No return to baseline, minimal variability. This is an emergency, and they did a C-section. And the pH was in the acidotic range. So what do we do? The quickest way to solve the problem is in the labor room, right? So we try to do intrauterine resuscitation, give mom oxygen, position changes to kind of, if the cord is compressed, to kind of, move the baby around inside the uterus, and maybe that cord will be less compressed and blood can flow easier. Turn off Pitocin if Pitocin is going on, right? We don't want to add any extra stress on the baby. And do the cervical exam, right? Maybe she's ready to deliver, and in one push, 2 pushes, this baby can come out. Maybe she's only 3 centimeters, and the baby doesn't look great now. We don't have all of labor to really wait to get a healthy baby. And while you're doing a cervical exam, we can also kind of tickle the baby's head. And what that is helpful for is if the baby responds with what's called an acceleration, right, where the heart rate goes up, we know that physiologically the baby is responding appropriately. So if we see that, then we're a little bit more reassured. If we don't see it, then we know that we have to act a little more quickly. Right, so what happens if we decide that it's an emergent situation and delivery has to happen right now? So then we kind of are deciding, how do we deliver this baby? Is this something we could do a few pushes? Is this something where we can still get a vaginal delivery by using assistance, vacuum, or forceps? Or do we need to go quickly back to the operating room for a C-section? So that's kind of what we're assessing. And there may be lots of people in the room to kind of help decide this. Anesthesia is very important, right? Like if you don't have any epidural going and we need to do an emergency C-section, we need them there to give what's called general anesthesia, where you're asleep. Or can we just dose up the epidural very quickly? And then of course, because we are concerned about the baby, right? We need to have a NICU team ready, or someone who is there specifically to help a baby that may come out needing some resuscitation or stimulation. All right, and then I will kind of end with this, but healthy mom, healthy baby is always the goal. And I know this is kind of like a tagline for obstetricians, and some people are a little irked by it because it makes people feel like we are discounting the experience of labor and delivery, but we do care very much about your experience. But for us, the safety of your baby does come first. Experience is second. And, there is always the ideal experience, right? But remember that labor is not predictable, and there really can be just unexpected situations. And we can't always predict them, but we can know what to do when we see them. So you may want to really talk with your doctor or midwife, like before you're in labor, about what to expect when the unexpected happens. Who does the C-section? When would you do a C-section? What type of team is available if my baby needs help? Just things to kind of prepare you for. So if an emergent situation happens and you don't have time to have a full discussion in the moment, because time is of the essence to save you or your baby, those are good questions to ask beforehand. All right. Super whirlwind here, but I think that's it. So thank you for joining us. And I think it's question and answer time.
Yes, thank you so much. So this is, we're going to move on to the next portion of tonight's event, which is going to be the Q&A session. I'm going to ask a few questions directed at both Dr. Hellman and Dr. Strauss. I just want to mention that this does not substitute for any sort of individualized medical advice. So we're going to start with the first question. We got actually a few asking about factor 11 deficiency. I will say that Dr. Strauss is a high-risk doctor and she specializes in these types of issues. So if anybody wants to answer, Dr. Strauss or Dr. Hellman.
Sure. So could you phrase the exact question for me?
I think that just to jump in, I think that we thought you had something to add to the factor 11, Dr. Strauss.
Oh, so just one thing is sometimes, women kind of like what Yardena said, don't have any idea if they have factor 11 deficiency, but doing actually a carrier screen can actually pick up that you're either a carrier of factor 11 or you have, or you carry both copies of factor 11 deficiency. And sometimes that's the way many people are picked up. And even if you're a carrier, it's important to see to let your obstetrician know and to see a hematologist during pregnancy.
Okay, thank you. The next question we got was about postpartum hemorrhage. So first, how do we measure like how much blood was lost? And then also what should patients know at home? How much is too much bleeding? And yeah, that's a question.
Yeah, so in the hospital after delivery, well, I'd say when it's happening, I think it's mostly identified by the person who is doing the delivery or the nurses soon after and being like, hey, that looks like a lot of blood, right? So it's not really a objective measure. It's kind of saying this looks like more than usual, right? So that's number one. Number two, there is kind of a trend now to literally weigh every like pad or chucks or gauze that has been used during the delivery so that we can actually get a very objective number of the amount of blood that is lost. And then if we see that it's higher than usual and kind of in the hemorrhage definition range, we kind of are a little bit more tuned in to watching for signs of mom not doing as well due to blood loss. It's also very important to look at the clinical picture and say, what's your blood pressure? What's your heart rate? How are you feeling, right? And so sometimes someone has had a hemorrhage and they're still feeling okay because their body's doing a really great job at compensating, and we don't really have to do much. We just have to watch the bleeding and make sure it doesn't get worse. So that's important. Now, when you're at home, really, if anything is concerning to you, you should always call your doctor, right? If you feel like, bleeding is going to be a little bit heavier than a heavy period for the first couple weeks after a delivery. But if you feel like you're having more than that, or you're like changing your pad every like 15, 30 minutes and it's filling up and you are starting to feel weak and lightheaded and dizzy, like those are signs to call your doctor. Though we bring you in, we check your blood count, we look at, do a physical exam and see what's going on. And if it looks like you're not doing well and your vital signs are dropping, then we have to like take care of it.
Okay, unless Dr. Strauss has anything to add. Okay, so the next question was, when would you recommend people discuss these sort of issues with their OBGYN or midwives? They feel that OB follow-ups are pretty short. Should they make a special appointment to discuss emergencies? When do you think would be a good time to talk about this?
I think you can bring it up at any prenatal visit, I think, and you may want to kind of think about all your questions ahead of time and, kind of space them out and digest the answers, based on like kind of what's relevant to you or what you're thinking about at the time. But like, that's the purpose of your prenatal visits, right? They're not just for us to check your blood pressure and your urine and listen to your baby's heartbeat. Like, that's your doctor's appointment, right? And if you feel like it's rushed, so maybe just like prepare your questions and go through like one or two, and then like your next appointment, kind of move on to the like less urgent ones or the ones that are not as applicable to that gestational age that you're in. But that's your time. I don't know if you'd agree. I'm assuming.
I completely agree with you. And I think also, like what you said, like what's kind of relevant to what part of the pregnancy you're in. Like if you're coming at like, I don't know, 7 weeks pregnant for your first visit, maybe it's not the best time to discuss, what type of delivery you want to have because you're only 7 weeks pregnant, and maybe talking about what's pertinent to like the next 5 or 6 weeks and taking it at a time.
Right.
Okay, yeah. And then there's another question about, is there a general medical consensus about how many C-sections are safe to have in a row?
You want me to take
That's
this? I'm fine. I can answer, but something.
Go for it.
Okay, so there's absolutely no rule at all. I think it really depends on the individual and what your body has done to heal itself, especially in regards to scar tissue after each C-section. So there are some people who've had one C-section and we go in the second time and it is like tons of scar tissue all over the place. It makes for a very difficult surgery. And there's some people who were on their 6th C-section and things look great and there's no problems. And, there's definitely risk factors for having repetitive C-sections, right? That layer of the uterine wall is not as strong and higher chance of uterine rupture spontaneously. And, so there are risk factors, but as far as like a hard and fast rule of you can only have a certain number of C-sections, there is none. Risk factors for those placental abnormalities that accreta, percreta, and creta, those do go up. So the more C-sections you have, there are higher percentages of these complications. So that's why it's something to kind of think about. But if each subsequent C-section is fine and your doctor should let you know, like, hey, this was a really hard one, or you had a lot of scar tissue, or that uterine wall was super thin, that's when you should be like, okay, maybe I'll think about this a little more before getting pregnant again. Like, is this something where like you would advise me not to, or am I still okay to have another baby?
Okay, the next question was if a person had a prior D&C, could that cause a postpartum hemorrhage or placental abruptions or issues?
Should I take this one too? It's not having the D&C that causes you to be at risk for the complication of postpartum hemorrhage. It's like, why did you have the D&C? If you had a retained placenta, could you have it again? And then maybe you'd be at like a higher risk for it, but it's not the D&C itself that's going to put you at higher risk of postpartum hemorrhage. Right? Would you agree, Dr. Strauss?
I agree with you.
Yeah, okay.
Okay, and then our last question was directed towards all of the MDs here. Did you find that because you knew so much about everything that can go wrong in pregnancy and childbirth, that your pregnancies you were a little more anxious during your own pregnancies and childbirth experiences?
And I would say,
yeah.
Denise, if you want to answer this also, you can. Anybody who, and Tirtza, you can answer your kind of what you think about going into it.
I'm gonna stay off video. Sorry. But,
sorry, no, I just wanted to say you could answer, but Dr. Hellman,
yeah.
I would love to hear what you have to say. Sorry, I cut you off.
I'm happy to share my my experience. Basically, I think that yes, it is a little bit nerve-wracking just because we know so much. But the important thing is to stay calm, trust the people who are also taking care of you. They always want the best for you, and stay positive as much as you can, because even at each stage of our pregnancies, we're seeing patients who are also at the same stage who might be going through difficult things and things like that, and that might make things more difficult for ourselves. It might make us more anxious, but in the end, the goal is to stay positive, like I said, think optimistically, and trust the people taking care of you.
Yeah, I would totally agree. I had, thank God, 3 very low risk, easy deliveries. And I think I had the opposite thought. It was more like, okay, I know it can happen. And like, I have people to help me if something goes wrong and I trust them, but I am knowing what can go wrong. I am so much more thankful that it didn't. Right. So that to me was like oh, thank God everything went well, because it totally couldn't have, because so many things can go wrong that like I deal with all the time myself and with my patients, that thank God everything was good.
I would say, I actually felt like during the whole pregnancy and labor and delivery process, I actually felt like the odds were overwhelmingly in my favor. Like, we see so much bad stuff, but at the end of the day, like, how many healthy women and babies walk out the door? So
Right.
I don't know if it's just our OBGYNs are so good or just, like in general, pregnancy, even though we spoke about a lot of scary things today, in general, pregnancy is low risk. And we're trained in our residencies for the kind of really rare percentage of the time where the bad stuff happens. So I kind of always had that. I always kind of had that reassurance. I personally had a fetal anomaly in a pregnancy and then became anxious because of that specific factor. So I kind of temper my answer a little bit with that.
Right.
But the actual labor and delivery process, I think I would, I even trust the residents. I hear a lot of times from a lot of my friends, oh, a resident delivered me. And I'm like, listen, that's more hands and more eyes on you than just one doctor. And I know that the residents are really well trained. So that would not be something upsetting for me at all.
Right.
I will
Agreed.
just plug in for my podcast that I did with Elissa Minkin, MD, about how I had COVID during my pregnancy and how that kind of threw a wrench in some of the way I was thinking about the pregnancy and how it went.
For sure.
I just want to address this question about the IVF making you higher risk than those who conceive through sex, Dr. Strauss. Oh, damn.
Did you lose it?
Are we still
Any
on?
answer?
I have it pulled up. Was the question, does having twins, triplets through IVF make you at a higher risk than those who conceived through just regular intercourse?
Yeah, so I was just going to answer. I know Dr. Strauss answered from a preeclampsia standpoint. I was going to say, unfortunately, IVF is higher risk for almost preeclampsia, a lot of complications in pregnancy, but the risk is not incredibly. Yeah, it's compared with the risk of not being able to get pregnant at all, and compared with all that we can do for it in with postpartum hemorrhage is what I was specifically going to say, and morbidly adherent placentas. But compared with everything that we know and everything we can do to mitigate the risk, it's a risk that I would still personally take. I think since we've lost video, should we end?
Yes, so thank you everybody for being here tonight. I'd just like to thank our speakers, Dr. Hellman and Dr. Strauss, for being here today. I'd also like to thank Mrs. Yardena Goldstein for being here and sharing her personal story. And lastly, I'd like to thank the Women's Health Committee for all of their hard work. Without them, these webinars would not be happening, so thank you. I'd just like to remind everybody that the post-session survey will be made available to you via email, and for those who fill out both the pre and post-session surveys, you'll be entered into a raffle to win a $50 Amazon gift card. So thanks again for being here today.
Thank you, Dr. Hellman and Dr. Strauss. Thank you, Tamar. Thanks, everybody.
Thank you.
Thank you.